Welcome, and thanks for joining us. My name is Jeff Bell, and on behalf of McLean Hospital, I'd like to pass along our sincere appreciation for your interest in our educational webinar series. Our focus today is twofold: bipolar disorder and schizophrenia. While BD tends to be characterized by intense mood swings and schizophrenia is largely marked by psychosis, the two can share common symptoms. It's also not unusual for someone with either condition to be struggling with other symptoms or diagnoses as well. So, our goal today is to help sort out what's what. And to that end, we have arranged to chat with Dr. Anne Shin, Director of Clinical Research in McLean's Schizophrenia and Bipolar Disorder Research Program. She is also an assistant professor of psychiatry at Harvard Medical School. Anne, thanks so much for carving out some time for us today.
Thank you so much for having me, Jeff. It's a real pleasure to be here.
Well, we are thrilled to have you with us. As I mentioned in our introduction, there can be some confusion between bipolar disorder and schizophrenia. And to understand that confusion, I think we first need to talk a bit about both conditions. Let's start with schizophrenia. Can you give us a working definition?
Yes, absolutely. So schizophrenia is a mental health condition that involves disturbances in thinking, in perception, in mood, and in behavior. And I think the hallmark of schizophrenia really is that individuals who are suffering with it have some loss of contact with reality. And so this can manifest with symptoms like hallucinations, which is the experience of hearing or seeing things in the absence of external stimuli, things that other people might not be seeing or hearing. It could be marked by something called delusions, which are, fixed beliefs, often, but not exclusively related to, ideas of paranoia or persecution. People can have thoughts that are somewhat incoherent or disorganized, hard to follow for other people, and that may be not tightly connected with one another. Also, behavior can be disorganized or erratic. And then, there's also some symptoms called negative symptoms. So the hallucinations, delusions, disorganized speech or thoughts, and the disorganized behaviors are what are called positive psychotic symptoms. And they're called positive psychotic symptoms, and not because it's some kind of value judgment or anything like that, but really it's an excess relative to what others might typically experience. Whereas negative symptoms are deficit symptoms. They are sort of the diminish, a reduction or deficit in symptoms in experiences that people might experience. So the negative symptoms are things like loss of interest, a reduction in the fluency or spontaneity of thinking or thoughts. It could be loss of motivation, apathy, things like that. So I would say that those are the things that really characterize schizophrenia: is the positive psychotic symptoms and then the negative psychotic symptoms.
And we'll talk much more about diagnostics of schizophrenia in just a bit. I did want to ask you about the prevalence. What do we know about how common or uncommon schizophrenia is?
Yes, absolutely. So schizophrenia is relatively you can see it as a relatively common illness insofar as about 1% of the population is affected. So, if you think about a room full of 100 people, one person in that room will be affected by schizophrenia.
How about causes?
Yeah, so the causes are very complex. Schizophrenia is a very complex illness. And, people tend to think of it as a chronic illness. And, we don't have a cohesive understanding of what schizophrenia is. However, there's been a significant amount of research on different areas of schizophrenia. And we know that there are biological factors, that there are psychological factors, and that there are social and environmental factors as well that can contribute. And in general, in psychiatry, we like to think of something called the biopsychosocial model, which is when we try to think about all the contributing factors that can lead to a person's illness. And so in terms of the biological factors, genes are important. So schizophrenia is quite heritable. And if you have a family history of a person with schizophrenia, that really raises your risk of schizophrenia. So if you have particularly a first degree relative, like a sibling, a mother, a father, or something like that, then your risk for schizophrenia increases. And then as of 2022, I think that is the most recent large genetic study that was done for schizophrenia. And that study identified almost 300 independent genetic loci that are associated with schizophrenia. So this is not an illness that is caused by one gene that is abnormal or mutated. And if you have that gene, then you will get schizophrenia. This is not that kind of illness. This is a disorder where the more genetic loci that accumulate that you happen to have, these are small changes in genes. The more you have, I think that is what increases your risk genetically. And then in terms of other factors as well, we know that schizophrenia is an illness that, even while it typically manifests in late adolescence, early adulthood. So we're talking about, someone who's age 17, 18, 19, 20, up to 30s. So that's usually when the first episode of psychosis tends to manifest. However, we know that these are neurodevelopmental disorders, that things are happening long before the first symptoms manifest. And so there are developmental brain changes that are happening as early as in the womb. So even in utero, things that are happening within the womb can increase your risk for schizophrenia. So, obstetric complications are associated with an almost 2 times increased risk for schizophrenia. Things like maternal flu, malnutrition during pregnancy, those are all things that can increase the baby's risk for schizophrenia later in life. And then other social and environmental things, we know that living in an urban environment has been associated with a slight increase in schizophrenia risk. We know that childhood trauma. So, increasingly we are understanding that, things like childhood maltreatment, childhood neglect, physical abuse, sexual abuse, all those things can increase the risk of any kind of psychiatric disorder, including schizophrenia. And that risk for psychosis can be as high as three times, threefold. And, even things like, being an ethnic minority in an area, a neighborhood that has a low density of your ethnicity can also increase risk. So, schizophrenia is an illness that's associated with, all these things, like all these risk factors. The more risk factors you have, the higher your risk becomes. It's sort of like a cumulative thing. Multiple hits, both biological, psychological, social, can all increase the risk of schizophrenia.
Let me ask you one specific question. In terms of risk, is there a distinction between gender?
So, in terms of risk, men and women, the rates are equal, generally speaking. However, the manifestation, so the illness can present a little bit differently. So, in women, the onset can be a little bit later. So rather than, 18 to 25, it can be more like in the mid to later 20s. And then there's actually a bimodal distribution. What I mean by that is that there are in the population 2 different peaks at which women can experience the onset of schizophrenia. That is in their 20s, in adulthood, And then there's like a second peak around, menopausal changes where women can have an increased risk for psychosis then. And that's related to changes in hormones. Estrogen is actually protective in psychosis, and as you lose, levels of estrogen in the body, a person who's susceptible to schizophrenia, they might see a little. There's like a peak there.
I want to talk a little bit about diagnosis and assessment. And at the risk of getting us off into the weeds, we don't want to get too specific in terms of some of the assessment tools per se. But what does the process itself look like? Is there a medical exam? Are there lab tests, the psychiatric evaluation? What sort of protocols are there for identifying schizophrenia?
Yeah, no, that's a very good question. So for schizophrenia, for all of psychiatric disorders in general, we have no lab tests. There are no brain scans. There's no specific test that will lead to a diagnosis of a psychiatric disorder, including schizophrenia. So, as a field, that's a major challenge for us. Unlike cancer or, heart disease, there aren't these like clear biomarkers that we can order to determine a diagnosis of whether a person has or does not have schizophrenia. I can kind of go into, since we don't have those, then what do we use, right?
Yeah, please do walk us through those.
Yeah. So, the diagnosis is based primarily on an interview, a clinical interview, and listening to what the person's experience has been, what's causing difficulties for them. And we may use lab tests and we may use brain scans, but these are not to diagnose schizophrenia, but rather they are meant to exclude other causes of psychosis and things that could look like schizophrenia. So to take a step back, psychosis is a very broad umbrella, very broad constellation of symptoms. A lot of the things that I already mentioned, the disturbances in thinking and perception and mood and in behavior, leading to hallucinations, delusions, disorganized thinking, disorganized thought. Those things can manifest not just in schizophrenia, but in a whole host of other psychiatric disorders, and in neurological conditions, in non-psychiatric medical conditions. And a lot of people tend to be surprised by this. There are people who are not treatment seeking, who don't have psychiatric disorders, who can also experience things like hearing voices, what we might call auditory hallucinations. And these are part of the general population. People, might call these individuals like healthy hallucinators. And there are a subset of the general population who can experience this, and that is not necessarily pathological. It's not necessarily indicative of a disorder. So when you have such a wide number of different conditions and situations that can lead to some of these things like hallucinations, delusions, disorganized thinking, and disorganized behavior, you want to be able to start to think about, like, is this schizophrenia? Is this something else? Is it, bipolar disorder? Is it another psychiatric condition? Is this part of a neurological condition? And so those lab tests and brain scans can help to rule out the neurological and some of the non-psychiatric general medical conditions, and then narrow things to, well, if it's not those things, it's more likely to be something psychiatric. And then within the psychiatric, that's when you start to use the diagnostic criteria to start to parse out, is this more likely to be this disorder or that disorder?
And there are very specific tools for that assessment itself, the DSM, for example.
The DSM, yes, which has its limitations and challenges, but it is currently what we have.
Well, let me ask you one more layer to that question. We've talked a little bit about what a professional might do to assess schizophrenia. What about a loved one or an educator in terms of looking for just basic signs? Are there some red flags to be watching for?
Yeah, so there are absolutely. So I think that I've talked about some of the symptoms of schizophrenia that, um, in some way are they feel a little bit checklisty, hallucinations, delusions, disorganized thinking, disorganized behavior, and negative symptoms. But I think that, you know, if you take a step back and look at the trajectory of an individual. So, you have a young person who is engaged, they're doing well in school, they have friends, they have interests and hobbies, whether it be sports or, art or whatever. And then you start to notice that that person is starting to become more withdrawn, perhaps more isolated. Maybe some of their interests are starting to drop off, and or they might be having a lot of um, anxieties. I think that you might want to start to that doesn't mean that a person has a psychotic disorder by any means, but that's a good time to sort of check in with the young person and try to figure out, like, what are you feeling, what's going on, um, what are some of the things that matter to you, what are your concerns, because I think that those are potential indicators of a person who's at high risk, or at a little bit higher risk of developing not just any psychiatric disorder, but potentially of a psychotic disorder. And if you can talk to them, a lot of individuals long prior to that first episode of psychosis, where you have frank, florid symptoms, they might experience very subtle disturbances of self-experience. And these are things such as starting to feel like maybe you're not quite immersed in yourself and in the
Mm.
world. And these are really hard things to articulate and describe. We have so many limitations of language. And so a young person might have a hard time talking about it, but if they say something like, something is wrong, something has changed, um, I don't have the words to describe it. That's like a common thing that people say in that kind of prodrome to the first episode, that something's wrong. They wish they can describe it better, but they're feeling off, not themselves. And they might have feelings that the world is feeling a little bit unreal and illusory, that things are starting to feel ungrounded. And this can cause a great deal of anxiety, as you can imagine. So those are kind of things I think to try to elicit and talk to the young person about.
And one of our goals with this webinar series is to work in as many audience questions as we can. And you are getting
Sure.
a lot of questions coming
Okay.
in. So let me start by just weaving this one in here. Does schizophrenia ever present in older adults possibly experiencing dementia?
Oh, that's a great question. So in that scenario, we wouldn't necessarily call it schizophrenia, but absolutely in older individuals, especially individuals who have dementia, psychosis can very much be a part of the picture. And people can start to feel paranoid, a little bit of paranoia, a lot of suspiciousness about the intentions of others. People can experience perceptual abnormalities, such as, hearing voices or seeing things that other people aren't seeing. So absolutely, psychosis can be seen in older individuals, especially in the context of dementia. So as I mentioned, when I talked about the broad umbrella of psychosis, absolutely under, I guess you could categorize it either as other psychiatric conditions, and or as a neurological condition. Dementia would be one of the things that could lead to psychosis. Absolutely.
One more very specific question. Are there any scales to measure insight of individuals with schizophrenia?
Insight.
Insight. I'm imagining that to be self-awareness, but I don't know.
Yeah. So, before I answer that question, I think that for people who don't know, when a person with schizophrenia is experiencing all these things, the first thing the first thing they're thinking is that this is actually happening, right? Like that, maybe it's the CIA, the NSA, all of law enforcement is out to get me. My neighbors are watching me. People are stealing thoughts from me. These are all things that feel very, very real. They're happening. And the last thing that individuals with schizophrenia are thinking is that this is a mental illness. This is the kind of insight that comes much later for many people after, often after some treatment. And it can actually take multiple rounds of recurrence of symptoms before people start to develop a good sense of insight. And so, part of the difficulty of schizophrenia is this sort of loss of or reduced insight that people can have that this is actually a psychiatric condition or a medical condition rather than something that's actually happening and that everyone is sharing that experience with them. So in terms of insight, there are there are actually several different assessment tools for insight, often used for research. These are not commonly used tools in clinical practice, I would say. But they are certainly available. I'm not able to tell you right now, off the top of my head, what the names of these are, but I'd be happy to sort of, provide a list of those,
Sure.
after the webinar.
Great. And one more very specific question that came in before we talk a little bit about treatment. In teenagers, from a school counseling point of view, I do come across several cases of psychosis in the age range of 12 to 18. Is there an assessment that could be used by a non-clinical person like a school counselor to make a more concrete referral to a specialist for further treatment?
Yes. So, there are screening tools, especially for symptoms that are occurring in what's called the prodrome, so the period leading up to that first episode. And, one of them is called I think the prodromal screening. I mean, it's a very kind of the name is very descriptive of what it is, the prodromal screening tool. There are a couple of others. Again, these are all things that, I could provide a reference to after the webinar, but there are some, definitely that can be used. And I think even the Mental Health Institute of America, they have like a website that has, various screening tools like this that are available for the public. But again, I kind of want to caution that screening tools are only screening tools. They should certainly not be used for the purpose of either self-diagnosis or of diagnosis of things like schizophrenia or any other psychiatric disorder by kind of the lay public. These are things that would help you bring to attention something that might be of concern that would need further evaluation by a health professional.
Yeah, I mean, that's such an important point too, Anne, is we really can't overstate the importance of working with a trained professional when you were talking about disorders such as these.
Yes, absolutely.
Before we shift gears and talk about bipolar disorder, let's talk a little bit about treatment for schizophrenia. What is the gold standard approach?
Yeah, absolutely. So, in schizophrenia, I think the best approach is to use, multiple modes of treatment, including medications as well as therapy. And therapy can be individual therapy, it can be group therapy. And because, oftentimes schizophrenia can be associated with impairment in academic function, and other, kind of functioning, whether it be social, work related, school related. I think that, getting some kind of psychosocial rehab would also be important. A really critical point with respect to any kind of treatment in schizophrenia and actually in all psychiatric disorders is this concept of early intervention. So the earlier that you can identify, that someone is having challenges and can provide a person with support, resources, and treatment, I think the better. And increasingly in schizophrenia, we are starting to think a lot more about treatments that are stage specific. So rather than think about schizophrenia as one monolithic illness that you treat always in the same way. You want to think about what stage the person is in, not unlike the way you would think of, cancer. Like you would not treat everyone with cancer with the same chemotherapy and with the same dose of chemotherapy and the same frequency. I mean, you may not even use chemotherapy at all. If you're in an early stage and you're able to detect that tumor or whatever very early, then maybe all you need is an excision, just remove that tumor and you're good. Whereas later, if the cancer has spread throughout the body, if it's metastatic, then you're going to have to use things like chemotherapy, radiation therapy, in addition to potentially surgery. So, I think that you want to think about schizophrenia and other psychiatric disorders in this kind of stage-specific way. Depending on where the person is in this stage of illness. So if a person is in the first episode, there's actually what's called coordinated specialty care programs that have been developed in the past 10 to 15 years, especially in the United States. These kinds of specialized programs have existed elsewhere in the world, in the UK, in Europe, in Canada, and Australia for quite some time. But it's really in the past 10 or so years that these specialized, coordinated specialized care programs, these are first episode programs, have come into development. They have been heavily subsidized by the US government, by the Department of Health and Human Services, and they really try to provide the support and treatment using a comprehensive, multimodal, interdisciplinary approach to care as early as possible in the first episode. So I would say, if you have someone early in the illness, try to find a first episode program like this. There are many throughout the country now. I think more than 300. So those are the kind of care programs to look for.
We will have an opportunity to circle back and talk much more about treatment for schizophrenia, but I do want to continue painting the landscape, so to speak, of both schizophrenia and bipolar disorder.
For
So
sure.
let's shift to BD a little bit here. Again, I'll ask you for a working definition. What is bipolar disorder?
Yeah, bipolar disorder is also, a mental health condition in which, a lot of the same kinds of symptoms can manifest. So we're talking about, disturbances in thinking, in perception, in mood and behavior. However, bipolar disorder is really a primary mood disorder rather than a psychotic disorder. So, this is more characterized by extreme mood swings, extreme fluctuations, alternations between mania and depression. And, by mood swings, I'm not talking about a person who, is having rapid mood swings necessarily within the course of an hour. We're talking about this being discrete episodes, discrete periods of time that are really distinctly different from the individual's typical mood and functioning and characteristics. So, mania would be the highs. So a person feeling very high, hyper, feeling, maybe euphoric. Um, and then depression would be the opposing end of that, where people might feel extreme sadness, melancholy, feeling very blue. And, this is, these extremes of mania and depression are obviously beyond, the typical realm, because all of us experience these emotions, right, of
Sure.
happiness and sadness. But these are really, more discrete and distinct episodes where people are feeling this way for more days than not for most of the day. And for depression, we think of a major depressive episode being 2 or more weeks of feeling that way. And for mania, we often think of it as being 7 or more days of feeling the extremes of euphoria and hyper and feeling high.
We often hear about bipolar 1 versus bipolar 2. What should we know about that distinction?
Yeah, absolutely. And, so bipolar 1 disorder, at least this is where I'm going to a little bit talk about the DSM criteria. Um, all you need to be diagnosed with a bipolar disorder is just one manic episode. Um, so it's common for people to experience both depressive episodes and manic episodes, but the depressive episodes aren't required for a diagnosis of bipolar 1 disorder. You just need to have had one episode of mania in your life, and that's it. Bipolar 2 disorder, on the other hand, this is different from bipolar 1 disorder in that the prominent mood state is more depressive episodes. So you have to have depressive episodes as well as, one or more hypomanic episodes. And hypomanic episode is when you have a lot of the same symptoms as you would see in mania, and I can talk about what those are, except that they may not be as severe, so not leading to psychosis or hospitalization, and they might not necessarily lead to functional impairment or distress in hypomania, and the duration is also a little bit shorter.
Okay. What about causes? Do we know anything about genetic components for bipolar disorder, for example?
Yeah, so it's quite a similar picture. Again, thinking about the biopsychosocial model of thinking about psychiatric disorders, there are going to be biological contributors to bipolar disorder, psychological as well as social and environmental factors that can increase a person's risk. In bipolar disorder, again, genes play a role. And as of the last publication that I'm aware of, there are at least 30 independent genetic loci that are associated with bipolar disorder. And it's there are a lot of similar shared genetics with schizophrenia, interestingly. So if you have a first degree family member with, schizophrenia or bipolar, it can increase your risk of bipolar or of schizophrenia. Does that make sense? So, I mean, there's evidence that the genetics may be somewhat similar for both disorders. And that's not surprising, therefore, that some of the clinical presentation can be very confusing and look quite similar.
And we're going to zero in on that in just a moment here because that's such an important topic. Great question came in from a viewer that I want to put into the conversation before we move forward. Can bipolar 2 shift over to bipolar 1 at any point? And I guess that we could ask the opposite of that as well. Do we see transitions from one form of bipolar to another?
It's not common. I mean, if you have bipolar 1 disorder, then you will not subsequently be diagnosed with a bipolar 2 disorder because, you've already demonstrated in your life that there has been a manic episode. So I don't know if that makes sense, but all you need is one manic episode to be diagnosed with bipolar 1 disorder. And so once you've had that manic episode, like the bipolar 2 is sort of off the table. You have sort of a more severe form of the illness. Bipolar 2 can now transition to bipolar 1. I think that it's possible. It's not, I don't know what the percentages would be. The difficulty with diagnosis of bipolar disorder is that for most individuals, depression is the presenting symptom. And if you have depression, then that's most often going to be diagnosed as major depressive disorder, what we think of as depression. people should have in the back of their head, if you're a clinician, you should be always thinking about there is the chance that this person who has depression can have bipolar disorder. We just haven't seen that manic or hypomanic episode yet. Because, again, the presenting symptom is often depression and not hypomania or mania. And so, the reason why this is important is because when a person presents with depression, a primary care doctor, a psychiatrist is typically going to prescribe an antidepressant. These might be, SSRIs, SNRIs. And if a person has bipolar disorder, those medications are potentially harmful for bipolar disorder and can actually trigger a manic episode or worsen the course of illness for a person with bipolar disorder. So there's often long delays in diagnosis of bipolar disorder. On average, the statistic is 10 years, delay of 10 years before a person appropriately gets diagnosed with bipolar disorder. And it's not necessarily because someone is, not doing their job. It could just be because the person's presenting primarily with depression. They're not presenting to their doctors, when they have a hypomanic episode because they're not seeing that anything's wrong. It just feels good, or it could be that they just haven't had that hypomanic or manic episode for years, and so that can also happen. That can happen when a person has depression. It can happen if a person presents with depression and then their primary care doctor or psychiatrist sees that they've had a hypomanic episode. And then later on, they can have a full-blown, more severe manic episode that needs hospitalization. And then, that's when you would be like, well, the person does not have major depressive disorder, nor do they have bipolar 2 disorder. They have a bipolar 1 disorder. So in that way, you can have that kind of transition. Sorry, it's a little bit of a
well, no, I think you're giving us a very good idea of why these diagnoses are so complex. Let's talk briefly about treatment for bipolar disorder. What should we know about the primary approach?
With a bipolar disorder, the mainstay of treatment is mood stabilizers. And again, therapies. And with regard to mood stabilizers, people might wonder what I mean by that. One of the gold standards as a mood stabilizer for bipolar disorder treatment is lithium. And lithium is a naturally occurring salt. It is an element in the periodic table. And, it is very effective for treatment of mania and for treatment of and prevention of depression as well, so of recurrences of mania and depression. There's another class of medications for the treatment of bipolar disorder called the anti-epileptic medications. So these might be things like valproic acid, carbamazepine, lamotrigine. These are all in the class of anti-epileptic medications that are often used also for mood stabilization. And then there's a whole, there are a number of, we haven't talked about in the context of schizophrenia, the medications necessarily, but a lot of the medications that are used for schizophrenia, especially the atypical antipsychotic class of medications. These are medications like olanzapine, risperidone, quetiapine, aripiprazole. These are all medications that are FDA approved, not just for schizophrenia, but also for treatment of bipolar mania as well.
We have promised throughout this conversation to talk about the confusion between these two disorders, between schizophrenia and bipolar disorder. There is so much to cover on that front. Let's start with the co-occurrence of the two. Can that happen?
So in terms of the word co-occurrence, I would say the symptoms can be very similar and can be very overlapping and can kind of coexist. So if we're talking about mood symptoms and psychotic symptoms, they can kind of coexist and co-occur. But the two diagnoses per se of schizophrenia and bipolar disorder don't really co-occur. You're going to be diagnosed with one versus another. And I know that this can be a very confusing area if you look at a clinical chart for somebody, for any patient, oftentimes the chart will say, in terms of like the problem list or the various diagnoses that the person has, might list schizophrenia, bipolar disorder, schizoaffective disorder, which is something that we haven't quite talked about here yet, but I'm happy to do that. They might have all these different psychiatric disorders listed, but I think what that speaks to is sort of a lack of clarity about what the person has. Oftentimes, I personally believe in parsimony, and it's not that a person has all these disorders. It's sort of the same, one disorder manifesting with the psychotic symptoms and the mood symptoms. And they can be kind of explained often by either schizophrenia or by bipolar disorder, or again, the schizoaffective disorder. Just really quickly, schizoaffective disorder is when you meet all the criteria for schizophrenia. So, the symptoms related to hallucinations, delusions, disorganized thoughts, disorganized behavior, and people may have negative symptoms as well. But the illness course is additionally marked by prominent mood symptoms, whether that be episodes of major depression or episodes of mania. So in schizoaffective disorder, you have a real combination of both the mood and the psychotic symptoms. Whereas in schizophrenia, it tends to be more psychosis. It's a psychotic disorder primarily. And you can also have mood symptoms. They might not be quite as prominent as in bipolar disorder. And then in bipolar disorder, that really is primarily a mood disorder, not primarily a psychotic disorder. It's primarily a mood problem related to these fluctuations between mania and depression. And when the illness is severe, that's when you get the psychotic symptoms. And you can get the psychotic symptoms in the mania, or you can get the psychotic symptoms in the depression. And about 60% of people with bipolar disorder have psychotic symptoms.
Wow. That's a pretty significant number.
Yeah. So when if there's anyone in the audience who happens to, be a clinician on an inpatient unit or in the emergency room, when a person presents with hallucinations, delusions, disorganized thoughts, disorganized behavior, mood symptoms, it can be very, 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 very difficult in that cross section in time to know without additional history if a person is experiencing the symptoms of schizophrenia or experiencing the symptoms of bipolar disorder. They can look almost identical.
Which really speaks again to the importance of working with trained professionals who can tease out what's what.
Exactly. And and the trained professional, it's not that there's some kind of like, magic that trained professional does. It's really about knowing how to gather the right information to be able to parse that out. And it's information both from the patient. The patient is the expert in their own experience and in what they're experiencing and in their symptoms. So talking to the patient, observing some of the symptoms, a person with mania, when they're sitting with you, you definitely feel it. Some of it's a little contagious, that like euphoric feeling. There can be a real charm, and like they seem so fun, and they're dressed in a fun way. They can be incredibly engaging. And so you can observe symptoms, you can ask about symptoms, you can talk to family members, people who know the individual well. You can look at past medical records. And again, you can use the lab tests and brain imaging and other tests to rule out what else might be causing some of these symptoms of psychosis and mood.
I want to tap back into our viewer questions because there are some really good ones coming in. A lot of questions, I'm told, about potential links between drug use in teenage and early adulthood years and development of psychotic disorders. What are your thoughts on that?
Yeah, so the question is really about substance use and the risk for psychosis. It's a fabulous question, and you really can't talk about psychosis without talking about substances, because, again, under that large umbrella of psychosis, under which schizophrenia is like a narrow slice and bipolar disorder is a narrow slice, you know, um, substances, in intoxication, you can see psychotic symptoms. In substance withdrawal, you can see psychotic symptoms. So, for example, intoxication with either cannabis, marijuana, hallucinogens, like, acid, LSD, sometimes with MDMA. With all of these substances that are recreationally used, you can induce a state of psychosis. Um, and then in withdrawal, particularly from alcohol, a person who has been drinking daily for many, many years, when they suddenly don't have access to alcohol, they can go into a withdrawal syndrome, which in more severe states can turn into something called delirium tremens. And in delirium tremens, you can have hallucinations, you can have delusions, you can have all these disorganized thoughts and behaviors. So both in intoxication and withdrawal from substances, you can see psychosis. And then it gets even more complicated because many people who are having, these unusual experiences can, and maybe in the mania or in the depression, there can be sort of this, you know, attempt to self-medicate, right? So, you may self-medicate with various substances, and that can actually increase or worsen some of the symptoms. So it's a very complex and complicated matter. And so you can, in addition to having intoxication and substance withdrawal be causes of psychosis, you can actually have a diagnosis of substance-induced psychotic disorder. This is when, it seems the onset of the symptoms of psychosis are triggered by substance use, often marijuana, again, or hallucinogens. But even if when they're not intoxicated, the symptoms are persisting and they may occur for weeks, for days to weeks, and even up to a month or so. So that is what's called a substance-induced mood disorder or psychotic disorder, depending on what are the symptoms that you're experiencing. But at some point, if those symptoms persist beyond, I would say, like a month or a few months, in the absence of continuing to use those substances, then you really have to think about, hey, this is unlikely to be a substance-induced psychiatric disorder. If the hallucinations and delusions persist, then you really have to think about this is more likely schizophrenia, or this is more likely bipolar disorder. And then to add another dimension and layer is that many people with psychiatric conditions, including people with schizophrenia and bipolar disorder, have co-occurring substance use disorders. So, about 80% of people with bipolar disorder have a substance use disorder that is diagnosable, like at the threshold level by DSM-5. And, at least in McLean, in the first episode clinic here, at least 60% of people have, some kind of substance use disorder as well. So these are high rates of co-occurrence between the psychiatric condition and the substance use condition.
Another very specific question that came in. Once it is diagnosed by the clinician that a person has schizophrenia, when should that person be told about his or her illness? Will it be a shock to that person? Will it cause them more distress?
That's a fantastic question, and it really speaks to the idea of stigma, right? Stigma associated with some of these conditions. And, I think that it's going to depend very much on the individual that you're working with. You have to think about it from person to person, a very individual case by case basis. Some people really like to know and are very much helped when they receive a diagnosis because somehow the diagnosis then allows them to explain or to provide a framework for understanding the experiences that they've been having, as well as to seek treatment. For others, it can feel quite demoralizing or discouraging to receive a diagnosis, whether it be schizophrenia or bipolar disorder, um, because there may be stigma associated with it, the meaning that they attach to that diagnosis can be quite distressing. And so I think that in our society, there tends to be this idea that schizophrenia, that you cannot recover from it, that it's something that is cause for hopelessness and despair, and that it means that you can't lead a fulfilling and meaningful life. And that's something that I think is important to dispel, that conceptualization of schizophrenia or bipolar disorder, that these are illnesses that yes, they are chronic illnesses often, but people can lead very meaningful and fulfilling lives. In schizophrenia, there's like a rule of thirds. About a third of people can actually recover. About a third of people remain approximately the same. And then about a third of people actually get worse. So, there is definitely hope. We need to do more to improve the treatment of these illnesses, but there's definitely hope. And so I think that, so absolutely the diagnosis, if you are thinking as a person that schizophrenia means my life is over, or that I have to rethink all the goals that I had for myself, then it could be very distressing. So, if you are going to give a person a diagnosis of schizophrenia or bipolar, I think there needs to be a lot of education around what that actually means, not what people in society perceive it to mean, but what the facts are. And again, these are very treatable illnesses. Can you cure them? Not at the moment, but they're treatable. We have a large arsenal of medications that can be incredibly beneficial. And beyond the medications, recovery, the idea of recovery is something that really needs to be individually defined by that person who has the illness. And so it is not about eradicating symptoms necessarily, but it is about asking what matters to you? What would you like to do with your life? What are your passions? What are your hobbies? What are your interests? What are the values that matter to you? And working with that individual to make that happen. Because a person should absolutely still, go after their goals and pursue them, whether it be, to pursue a college education or go back to college, to get a job. All those things are very possible with both of these conditions. People can lead very meaningful lives.
I'm so glad you touched on both the power of hope and the roadblock that stigma can present. And it strikes me, Anne, that a big antidote to both of those is awareness. I mean, these sorts of conversations that we're having right now, just educating
Absolutely.
people about what schizophrenia is, how is it treated, what is bipolar disorder, how is it treated. And on that note, I want to ask you for any resources that you would recommend for either clinicians who are in the audience or parents or concerned folks who want to be able to help a friend or a loved one living with schizophrenia or bipolar disorder. Are there websites, favorite books, anything else you'd like to put out there for resources for our viewers?
Absolutely. So, first of all, I'm here at McLean Hospital, and McLean has so many resources. So if you check out the McLean website, you can find a wealth of information. There is and everything you need to know about schizophrenia. You know, um, a resource there about that. Everything you need to know about bipolar disorder. I was involved in helping to make the scripts and working with a Cambridge-based animation studio called Planet Nutshell, where we made these very brief animated videos about both schizophrenia and bipolar disorder, which you could find on the McLean websites. And obviously, Jeff, the work that you're doing to create these webinars, I know that you've done webinars also with Dr. Joost Unger, who's the division chief of the McLean Psychotic Disorders Division on suicide assessment and treatment in psychotic disorders. There's been one with Kirsten Bolton on navigating the ups and downs of bipolar disorder. A previous webinar about bipolar and schizophrenia with Dr. Eve Lewandowski. So I think those are all great resources. And then for patients, I want to, if you are able to find this resource, it's really a great, very brief read. There is a paper in the journal Schizophrenia Research from 2020 by Ellen Sachs. And Ellen Sachs is a very well-known professor of psychiatry and law at the University of Southern California. And she's written a memoir that's been critically acclaimed, widely received, called The Center Cannot Hold. And she wrote this very brief article, which is a letter to my younger self. And I just think it's fantastic. And the advice that she gives is very practical. And it's things like, it's basically saying things like working to make peace with your illness. I love how she said that, working to make peace with your illness, because she herself fought her diagnosis for so many years. And I think that is a common scenario for individuals. If you can work to make peace and try to better understand your illness, understand the factors that for you make things better or worse, and maybe making things better can integrate things like medications. People have, a tendency maybe not to like medications, whether it be because of side effects or what it means to them to take medications, but working to make peace. And if medications help you to live your life better, to attain your goals, then why not take those medications, right? If you have diabetes, you need insulin. Insulin's going to help you live your life more healthily. And for many people, I'm not going to say all people, but for many people, medications like antipsychotics really can help people live their life in the way that they want. It's like in the service of their goals, as opposed to it being the end all be all.
And this hour has flown by. My goodness, we have covered so much ground. I want to thank you again for being our guest today. We so appreciate your time and your commitment to helping educate folks about these important topics.
Thank you so much. It's a real pleasure. And thank you for inviting me to participate. I think this whole webinar series is incredibly important for, as we talked about, combating stigma and just making information about these conditions more accessible. So
Dr. Ann Shin. To those of you watching, thank you for your interest in our educational webinar series. We hope you'll come back for our future sessions, and we wish you a wonderful day.